The first thing is higher mental function. Higher mental function. Second, cranial nerve. Third, motor function or motor system examination. Fourth is a sensory function or sensory system examination. Fifth is a test for meningeal irritation. Okay, test for meningeal irritation. 6, cerebellar function test. 7, we ask the patient to walk in front of us to assess the gait, how the patient walk. 8, we examine for skull and spine. Are there any deformity or any abnormality? And the last one, we need to assess what are the autonomic functions. So one after other, okay, I will elaborate on this. You see here. Now, what are the higher center or higher mental functions you need to assess in the patient? Now, regarding these higher mental functions, in detail, you will study in psychiatry. Okay, these are a special part of the psychiatry, but nevertheless, in neurology, in case of internal medicine also, you need to know something about them. So see here, A stands for appearance. What is the general appearance of the patient? B is behavior, how the patient is behaving with us in our clinic or in the hospital. We should know about it. C stands for level of consciousness. This C, okay, level of consciousness, whether the patient is fully alert, whether the patient is fully cooperative, whether the patient is drowsy or sleepy or in coma. These are called level of consciousness. D stands for delusion, illusion and hallucination. This delusion and hallucination are very important feature of psychosis or psychiatric disorder. Delusion is false but very firm belief. False but very firm belief, from where it is very, very difficult, okay, to change the belief of the patient. This is delusion. I want to give you one example here immediately. If somebody says, okay, if somebody says, I am the richest person in the world, and you know this person is one of the poorest one, you don't believe that person, isn't it? So this is a type of delusion. This is called delusion of grandiosity. Okay, the person strongly believes he has a lot of money, but actually he doesn't have. And even if we counsel that person, no, you are wrong, the person is not ready to change the belief. So this is delusion. Now hallucination means, okay, hallucination can be a different type actually. It is a abnormality of perception. So if hallucination is a visual type, we call it visual hallucination. Some of the patient may see something which is not there. Okay? This is visual hallucination. The thing is not there, but the person is seeing that thing. Auditory hallucination means the person is hearing something where the sound is not there at all, but the person is hearing that inside his ear or her ear or inside the mind. And this is a very dangerous one. Sometimes that auditory hallucination can lead to suicide, okay, in a psychiatric case, because the psychiatric person can simply jump from the top of the building after hearing that voice inside his head. Jump, nothing will happen. So this is clearly a type of auditory hallucination. Tactile hallucination, okay, gustatory hallucination, there are different types. Now illusion is, okay, something is there and the person is seeing that thing differently. There is a subtle difference between illusion and hallucination. In hallucination there is no stimuli, there's nothing, no object is there, but the person is seeing that. But in illusion something is there, okay, the object is there, but the person is seeing it differently, the person is perceiving it differently. This is illusion. So these meanings are very, very important for you. Another is emotional state of the patient. So how the person emotionally is behaving. Is he depressed? Is he elated? Is he very happy? Okay, or is he fluctuating between the happiness or elation and depression? This is emotional state. Memory, okay, We ask certain question to the patient, probably something which the patient has done in the past, or it's something related to the person in the past, and the person has to memorize and tell us. This judges the memory. O stands for orientation to time, place and person. Very important higher center functions. Okay. Now orientation to time means what time of the day or what time of the night is, everyone should know. Place, right now where am I? Okay, everybody should know that. And person, a very close person, I should never forget those close persons. For example, dad and mom, okay, wife, children, okay, siblings. So these are the orientation to time, place and person. I stands for intelligence, S is for speech, J for judgment, and I for insight. Now those intelligence, speech and judgment are quite easy terminology, but insight means whether the person know whether he or she is ill or not. For example, one person has come to the hospital or brought to the hospital, okay. Now you have asked that person, do you think you are ill? Do you think you have certain disease inside you? If the person says, no, I'm perfectly fine. This a family member, my son, my daughter, my wife, they have just brought me here. Actually, I don't want to come here. I'm perfectly fine. That means the insight is very poor. Patient doesn't know what is happening. Okay, so these are a higher center function. Now, the second important part of central nervous system examination is cranial nerve function. Okay, now see here. Now we all know, or every student know, what are the cranial nerve. This is one of the favorite questions of the examiner. Okay, so please, even if you don't know or if you have forgotten, this is a very good time to revise them. There are 12 pairs of the cranial nerve in our body. 12 pairs. From first to 12. So first is olfactory, second optic, third is oculomotor, fourth trochlear, fifth is trigeminal, six abducens, seven is facial, eight vestibulocochlear, ninth is glossopharyngeal, 10th is vagus, 11th is accessory, and 12th is hypoglossal. You cannot change the order, okay? This has to be in the proper order. And this is a very basic question. And please remember one thing, if you even cannot answer what is the name of the cranial nerve, forget about other questions there. It gives very bad impression to the teacher. Now, how to judge olfactory nerve function? This is done by smell. Isn't it? Smell. So what we do, we take something okay, which is a sweet smell, and we take that in front of the nose and ask the patient to find out which object or which smell is that. It's very easy. Optic nerve, okay, is judged by these four things. Okay, three things are written here. One is color vision, which is not written. You can add that later. Vision means visual acuity. This visual acuity is done by Snellen's chart. Snellen's chart, which is available everywhere. Visual field, okay, visual field means how far the person can see when the head is still. How far on the temporal side, how far on the nasal side, how far superior and inferior part of the visual field. Okay, so when we start our practical thing, when we return back to our university, then I'll clearly demonstrate or show you how to do that. Okay, the third one is a light reflex. Just flash the torch light on the pupil and check whether the pupil constricts to light or not. This is called afferent light reflex or pupillary light reflex, you can simply say. And fourth one is a color vision. Just to know at this class what are the function we check. Okay, how to check, and those things are a very different class actually. So we'll do that later on. Third, fourth, and sixth cranial nerves are examined together because their function is a bit similar. They all supply extraocular muscles. Now see here, the third cranial nerve or oculomotor nerve, these are the different clinical action. Eyelid elevation. Eyelid elevation eye elevation means eyeball elevation, adduction, okay, depression in abduction, and the pupillary light reflex, which the efferent part of pupillary light reflex is also done by oculomotor nerve. Now, if you do not know about the neuroanatomy, it is very difficult for you to understand these things. Okay, so my sincere, advice for you, if these things are difficult, okay, you don't have any other thing to do now. So just open your neuroanatomy book and go through them. Try to know what are the pathway of cranial nerve, from where they originate, how they come out of the brain, which are the muscles they supply, what are their functions, and then only you know how to examine them. Trochlear nerve as intorsion of the eye means medial rotation of the eye, and depression in adduction. Okay, adduction and abduction, these are the two terms. Adduction means deviation towards the medial side. Abduction means deviation towards the lateral side. Okay, adduction is medial, abduction is lateral. So these are some of the terms. Abducens is abduction of the eye. Now, one simple question: which muscle is supplied by abducens nerve? Which muscle is that? Yes, who can answer this? Which muscle is supplied by abducens nerve? Okay, guys, I have unmuted you now. Can you answer?
Lateral rectus.
Lateral
For
rectus.
superior oblique.
Okay, fine. Lateral rectus. Okay, only one muscle, that is lateral rectus, is supplied by abducens nerve, and lateral rectus moves the eye laterally. So that lateral movement of the eyeball is called abduction. AB, abduction. So you always should remember one mnemonic, which probably in the previous classes also we have discussed, that is SO 4 and LR6. Never forget this. SO4 and LR6. This SO stands for superior oblique by fourth cranial nerve, which is trochlear nerve, and LR is lateral rectus by sixth cranial nerve. So these are very, very important points. All other extraocular muscles apart from these two are supplied by third cranial nerve. Okay, third cranial nerve. So this is the take-home messages from this discussion. The fifth cranial nerve is trigeminal nerve. Okay, facial and corneal sensation is the function of trigeminal nerve, and muscles of mastication is also supplied by trigeminal nerve. Now, there are four names or four muscles which are called muscles of mastications. What are those muscles?
Masseter.
Masseter.
Buccinator.
Okay, one is masseter. Good. Anybody?
Buccinator.
Buccinator is not the muscles of mastication. Okay, it is a different one. Temporalis is second one, and third, medial and lateral pterygoid. Medial and lateral pterygoid. Okay, pterygoids. Now see here, these are called muscles of mastication, and one nerve supply all these muscles of mastication. What is the name of that nerve? Which nerve?
Trigeminal nerve.
It's a branch of trigeminal nerve. You have to be very specific. Okay, you are right, it's trigeminal, but which branch? This is called mandibular nerve. Mandibular nerve. Okay, see here, mandibular nerve. So this is the way you have to repeat or revise when these things you are going to study. This is the way. The whole thing is probably a bit difficult to revise at this time. Now, Seventh cranial nerve is the facial nerve. So facial nerve is responsible for movement of the face or contraction of the facial muscles, or we also call that facial expression, happy face, sad face. If I want some wrinkling on my forehead, if I want to deviate my mouth to one side, all these are done by facial muscles, and these are supplied by facial nerve. Not only that, okay, not only that, the anterior two-third of the tongue, the anterior two-third of the tongue, let me write this for you, anterior two-third of the tongue is also supplied by facial nerve, and this is regarding the taste sensation. Okay, posterior one-third of the tongue regarding taste sensation is supplied by glossopharyngeal nerve. So never forget this. Anterior two-third of the tongue regarding taste sensation is by facial nerve. Posterior one-third of the tongue regarding taste sensation is by glossopharyngeal nerve. Now, the eighth cranial nerve has two functions. The name itself suggests vestibulocochlear. Vestibular is for balance, cochlear is for hearing. Ninth cranial nerve is glossopharyngeal nerve. You can just do two important tests for that. One is sensation on the back of the throat or near the soft palate. Just take a cotton applicator and touch on the back of the throat. Okay, you can clearly find out whether the patient still have sensation there or not, because that is done by ninth cranial nerve. And gag reflex is also maintained by ninth cranial nerve. Gag reflex we say, because if we touch posterior pharyngeal wall, there is a sensation of gag. Okay, the whole pharynx tries to be elevated up, and the patient wants to vomit it. This is called gag reflex. This is a function of ninth cranial nerve. Posterior one-third of the tongue regarding the taste sensation is also by ninth cranial nerve. So these are the functions. Now, what about the 10th cranial nerve or the vagus nerve? The main clinical actions of the vagus nerve are, okay, cough reflex, palatal and vocal cord movement. All of these are done by vagus nerve. I'm again getting some disturbances here. So again going to mute now. Now see here, cough reflex, palatal and vocal cord movement, all of these are done by vagus nerve. Vagus nerve is one of the very long nerve, and one of the most important nerve is the parasympathetic cranial nerve. Okay, accessory nerve is the 11th one. Okay, so it is responsible for two muscles, sternocleidomastoid and trapezius. So turning of the head, okay, on the side and shrugging of the shoulder is the function of accessory nerve, which is supplying two important muscles. And the last one is a hypoglossal nerve. This supplies the tongue. This is a motor nerve of the tongue. So these are the cranial nerve. So let me remind you once again, please revise these, and after every topic, okay, I'll give you some assignment, and some of the assignment will definitely from this cranial nerve, so you need to go through them, okay, and write the answer. Let's move on. The third important part of the cranial nerve examination, the neurological examination, is motor function testing, or you can say motor system exam. And under this we have got 5 headings: bulk, tone, power, reflexes, and involuntary movement. Now let me analyze them one after other. Now what do we mean by bulk? Okay, what is bulk now? Now bulk means, okay, what is the size of the muscle on both sides? What is the size of the muscle on both sides? That is called bulk. So if I measure a size of the muscle on the right side and immediately compare to the left, I know which muscle is bigger, which muscle is smaller, or are they of the same size or not. This is called bulk. Why we do that? That's the important question you should ask yourself. Because in case of neuronal damage, okay, in case of nerve damage, if a motor nerve is damaged, the muscle which is supplied by that motor nerve will be atrophied. So if I do not measure the size of the muscle, I don't know whether that muscle is atrophied or not. This is the main purpose. Second point is tone. Second point is tone of the muscle. Now, how to judge the tone? Okay, see here. Now, how to judge the tone, and what is the tone first? So now I'm asking this question to the students. Can someone answer me? What do you mean by tone? Yes, please. Anyone?
Slow movement of the muscles.
Yes, Amin, say it again.
Slow movement of the muscles.
Okay. Any other answer?
Muscle contraction in the
Strength of the muscle.
Okay, wait, one by one, okay, because all the students are speaking at the same time, I cannot get it. Yes, Rana Atisam, tell me.
Sir, a little bit of contraction when the muscle is relaxed.
Okay, Sahabuddin, yes, Sahab. Okay, so let me answer this, okay?
Sir,
Yeah, please, yes.
tension in the muscle at rest.
Spasticity of the muscle. Spasticity of the muscle.
Okay, fine. All of you.
Power of the muscle.
All of you mute yourself. Now listen, okay? Listen the answer now. Now tone is when muscle is at rest, when we are not doing anything, when we are at absolute rest, even during that time, the muscle is contracting partially or a slight amount of contraction is happening inside the muscle. This is called tone. So let me repeat again. Tone is partial contractility of the muscle at the time of rest. Tone is not power. Power and tone are very different terms. Okay, so tone is when I am taking rest, when I am not doing anything, at that time also the muscles are not floppy, they are slightly in contractile state. That is called tone. Now power is, okay, power is when I want to do something, when I want to lift something, when I order the patient, okay, can you push me or can you pull me or something like that. When I ask the patient to lift some of the weight from the ground, okay, so when I ask the patient to lift their, limbs, upper and lower limbs, something like that, this is power. So judging the power is a very important one. I'll talk this a bit later. Reflexes, every student know reflexes. These are deep tendon reflexes or superficial reflexes. Okay, we'll talk about that. And they are abnormal in case of central nervous system diseases, and sometimes involuntary movement may be there, like some fasciculations in case of lower motor neuron type of diseases. Okay, some other involuntary movement like chorea, okay, some tics. So all of these can be there. So these are the list of functions under motor system which we like to examine in neurology. Now bulk, already talked about. Okay, see each muscle group whether they are normal or not, okay, whether they are atrophied or not, whether they are hypertrophied or not, whether there is any mass present inside the muscle or not. During examination it is quite obvious, but in case of neurology, the thing which we are discussing right now, atrophy and hypertrophy are the two things which we like to judge, especially atrophy. Fasciculation is twitching of individual muscle fiber. Twitching of individual muscle fiber is called fasciculation. It is a feature of lower motor neuron type of lesion. Now, what about the tone now? Okay, now I already talked about it. This is partial contractility of the muscle at the time of rest, and this is maintained by gamma motor neuron in the lower motor neuron. Means gamma motor neuron is a part of lower motor neuron. So this gamma motor neuron is responsible for maintenance of muscle stretch, which is called tone. Now tone will be increased in upper motor neuron lesion and it is decreased in lower motor neuron lesion. So increased tone is called spasticity. Spasticity, and decreased tone is called flaccidity. So increased tone is spasticity, decreased tone flaccidity. So remember, increased tone occurs in upper motor neuron lesion and decreased tone occurs in lower motor neuron lesion. Now some of the students may be confused what is upper motor neuron and what is lower motor neuron. So let me clarify you immediately. Upper motor neuron always start from the cerebral cortex and they end in two important areas. If we are talking about corticonuclear fiber, they end in brainstem. So this is upper motor neuron for the brainstem. Whereas if we talk about spinal cord, then corticospinal fiber, they end in spinal cord. So these are two important types of upper motor neuron now. You already know corticonuclear fiber and corticospinal fiber. Now what about lower motor neuron now? From the cranial nerve nuclei in the brain stem, nuclei is a part of lower motor neuron, the whole cranial nerve till it terminates is the lower motor neuron for cranial nerve. And regarding the spinal nerve, from the anterior horn cell of spinal cord, from there the whole spinal nerve till it ends is the lower motor neuron. So never forget this. Some abnormal tone are spasticity and rigidity, which occurs in upper motor neuron lesion. Rigidity is mainly a feature of extrapyramidal tract problem, whereas flaccidity is seen in lower motor neuron lesion. Now look at the power, how we examine power, and how we grade it. Now see that please. Now 5 means, grade 5 means full power, means normal power. The muscle is contracting quite well. It's a powerful contraction. Now 4 is active movement against the gravity and resistance. Active movement against the gravity and resistance. Now against the gravity, what do you mean by that? For example, the person is standing, I ask the person to elevate some heavy weight from the ground. So this is against the gravity, quite easy. It is against the gravity definitely. And on top of that, if I press his hand, if I press his hand or forearm downward and at the same time ask the patient to lift it upward, this is resistance. So against the gravity and resistance. So now it is very easy for you to understand. 4 plus is movement against a strong type of resistance. You are pushing very hard and ask the patient to lift it up. This is strong resistance. And 4 minus is movement against a mild degree of resistance. This is grade 4. Grade 3, active movements against the gravity without any resistance. You are not pushing there. You are just asking the patient to lift against the gravity. This is grade 3. Grade 2, active movement with gravity eliminated. There is no gravity now. Now one important question that should come in your mind, how can we eliminate the gravity? How is that possible? The answer is when we lie down. When we lie down on the bed, for example, ask the patient to lie down on the bed and then turn on the side, and lift the turn, or for example move the hand side to side, move the leg side to side. This is gravity eliminated movement. This is not up and down type of movement. During that time gravity would be definitely there, okay, but if I move side to side, then gravity would be eliminated. This is the meaning. One is a flicker of contraction, okay, also known as twitching, okay, twitching or flicker of contraction. And zero means absolute paralysis. There is no contraction of even one individual fiber. This is zero. So according to this scale, it runs from 0 to 5. 5 is full power, 0 is absolute paralysis. So this is how we judge the power. Now, what about reflexes? You see there. What about reflexes now? See here, please. Now, look at the name of these reflexes first: superficial reflex and the deep reflex. So this is a very favorite questions of the examiner. Any examiner, wherever you go for the examination: abdominal reflex, cremasteric reflex, plantar reflex, and anal reflex. These are the example of superficial. Okay, so even corneal reflex can be added there, but corneal reflex is not usually done in clinical practice. Okay, it may damage the eye if the examiner doesn't know how to do it, and that's why so others are quite commonly done, like abdominal reflex, cremasteric reflex, plantar reflex, and anal reflex. Now, can anyone tell me what is written here on the side? This T10 to L1, L1 to L2, L5, S1 and 2, S2 to S4. What do you mean by this? Yes?
Spinal nerves.
The fibers are coming from this vertebra.
Okay, very good. The answer is right. These are actually the root value. Okay, you can answer like this. These are the root value, means which part of the spinal cord is supplying those reflexes. This is the meaning, root value. So as a student, you should remember them. Like abdominal reflex, the root value is T10 to L1, means T10, T11, T12 and L1. Cremasteric reflex, L1 and L2. Plantar reflex, L5, S1 and S2, and anal reflex, S2, S3 and S4. So regarding the deep reflexes, which are also known as deep tendon reflex, in upper limb we are concerned about 3 important reflexes, and in the lower limb 2. So in the upper limb they are supinator jerk, the root value is C5 and C6, biceps jerk, C5 and C6 again, and triceps jerk, C7 and C8. Okay, supinator, biceps and triceps. Whereas in the lower limb we have knee jerk, L2, L3 and L4 is the root value, and ankle jerk is S1 and S2. So these things you have to repeat many times until and unless you are quite confident. Now let's see some of the picture, okay, how to do these reflexes. So let me take the help of pointer here. See here. So this is the demonstration of abdominal reflex. Ask the patient to lie down supine on the bed comfortably, okay, and you just stroke the lateral part of the abdomen or abdominal wall like this. See here, okay. Suddenly stroke from the lateral side, from the lateral towards the medial side, upper part of the abdomen and lower part of the abdomen on both sides, and you see the contraction of the muscle. If muscles are contracted when you stroke the entire abdominal wall like this, that means abdominal reflex is positive or it is present. One very important point is, in upper motor neuron lesion, abdominal reflex is absent, and definitely in lower motor neuron lesion also abdominal reflex is absent, because in lower motor neuron lesion reflexes are always absent. Okay, in upper motor neuron lesion also abdominal reflex is absent. So good morning all of you. So let's continue the discussion on neurological exam. That's what we are doing from the last class. Now, neurological exam comprises of higher mental function examination, which we discuss. After that, it's cranial nerve, then motor function, sensory function, okay, then cerebellar functions. What about the gait? Okay, what about the head and back? Then what about the autonomic function? So most of the things we discuss in neurology examination. Now, right now, we are talking about examination of the reflexes. Please mute yourself and listen properly. Now, cremasteric reflex is elicited by lightly stroking the superior and medial part of the thigh. See here, the picture is clearly showing us when we stroke the medial and superior part, also known as inner part of the thigh. It is done only in male, okay? Then you have to observe whether the testes or the scrotum on that side goes up or not. If it is going up, that means the cremasteric reflex is positive, and this is done by contraction of cremaster muscle, which is stimulated when we give this type of stimuli. Now, cremasteric reflex may be absent in some testicular disease like testicular torsion, upper and lower motor neuron disorders, as well as spine injury of L1 and L2, because the root value of cremasteric reflex is mainly L1. L2 also plays a role, but L1 is the main one. So in upper motor neuron lesion as well, cremasteric reflex is absent. There's no doubt in lower motor neuron it is absent, okay? It is very easy understanding. Some of the testicular disease also, testes cannot move up, so it is absent. Now, another type of superficial reflex is Babinski sign, also known as plantar reflex. Plantar reflex. Now see here how we do it. Okay, this is the way. Okay, let me explain with the help of a pointer here. See this. So examiner is taking some object, some sharp type of object, okay, which can stroke our soul, and the examiner is starting near from the heel area, okay, on the lateral side of the heel, and when the examiner reaches the base of the toes, then the stroke will go medially, exactly like this. It is started from here, from the lateral side of the sole, then when we reach the ball of the toes, then it will go medially. This is the way. Now you have to see the response. Okay, you have to see the response. Normally in healthy people, the great toe goes towards the ground and other toes are fanning, okay, sorry, they also coming together. But in case of upper motor neuron lesion, look what happens. The great toe is going upwards. This is called extension of the great toe, and other toes are also fanning outward, means they are separated from each other. So this abnormal type of plantar reflex is called Babinski sign. If it is normal, we don't call it Babinski sign. If it is abnormal, then only Babinski sign is called. That means it is present. Now you may be wondering why this picture is shown here, this baby's picture. Okay, in babies till 1 year of age, especially till 1 year of age, okay, there is no proper myelination of central nervous system neuron. So without proper myelination, the Babinski sign may be positive in them. That doesn't mean they are having upper motor neuron disease. The Babinski sign is usually positive in very small babies. Let's move on. Sorry. Okay. Now after Babinski sign, let's talk about some deep tendon reflexes, how we do it. Okay. So before I move on to each of the reflexes, let's talk about some physiology. What is the normal physiology of each of the reflex? Okay, this is called reflex arc. Okay, reflex arc. I'm sure you have studied this in physiology. Now see here, when we stroke, okay, any tendon, okay, okay, the sensation is taken by the sensory nerve, okay, because there is a vibration in the muscle which is taken up by the, you know, some stretch receptors in the muscle, and the sensory nerve will take it. Okay, the sensory nerve is shown in the red color here. So this sensory nerve will take the sensation, okay, to the dorsal, okay, root ganglion, where the ganglion is located, or cell body is located of the sensory nerve. Then it will go to the dorsal horn of the spinal cord. This is called dorsal horn. Now there is a synapse between sensory nerve and the motor nerve, and this motor nerve will take the order, or the, okay, the order out for the same muscle. So there is a contraction of the muscle which results in some action in that particular area. So this is the very basic knowledge about deep tendon reflex. Now if they ask you what are the component of deep tendon reflex, you can answer in a very easy way. Okay, receptor is one, then sensory nerve, then motor nerve. You can take spinal cord as the center here, okay, and then the effector organ. This muscle is called effector organ. So these are the important points. Now before we do the, you know, reflexes, or we elicit the reflexes, let's know how to use the hammer. Okay, this is the very easy diagram, or the, you know, picture of hammer. So catch the hammer always, okay, with your finger and release it very smoothly. The wrist should be flexed. You should not flex your elbow or the shoulder joint. The wrist joint should be flexed very smoothly and stroke to the exact area where you want to hit. This is how the hammer is used. Otherwise it will cause pain to the patient, and this is not a proper use as well. Sometimes when we are eliciting the reflexes, okay, sometimes when we are eliciting the reflexes, it will not come very easily. Okay, there is some resistance from the patient side. So just to, you know, ease for the reflex, or just to divert their attention, some reinforcement techniques are there, and they are called JENDRASSIK'S maneuver. So you can see very clearly in the picture, the examiner is trying to do knee jerk or knee reflex, and he has asked the patient to clench, okay, to clench the fist, okay, by locking the finger and pulling one against the other. So this is one of the reinforcement technique for the elicitation of lower limb reflexes. So this is called JENDRASSIK maneuver. For the upper limb reflexes, for example, there are three types of upper limb reflexes we usually do. Okay, biceps, triceps, and supinator. For them, if they are not easily coming, okay, then we ask the patient to clench the teeth, and we squeeze the thigh, or ask the patient to squeeze the thigh also. Both things can be done. So this is the reinforcement technique for the upper extremities. You don't need to do it all the time. Remember this, okay? If the reflexes are easily coming, you don't need to do it. But if there is some sort of resistance, if the muscles are not contracting easily, you can try for this. This is the meaning. Now, how to elicit biceps jerk? See here. Okay, catch the patient's hand like this near the elbow. Okay, take the knee hammer, okay, and then stroke in the biceps tendon. Now you need to exactly know where is the biceps tendon. I'm sure every student know that. Okay, ask the patient to flex and extend the elbow. When the person is flexing the elbow, you can feel the biceps tendon there. It is a big tendon, the biceps tendon. So feel it and hit it right there. Now what is the action when we hit at the biceps jerk? What is the action when I hit the biceps tendon?
Flexion of arm. Flexion of
Flexion of
arm.
the forearm.
Second of the
Forearm.
Very good.
Supination of
For
Exactly, absolutely. Flexion of the forearm, flexion of the forearm. This is the main functions of the biceps. Another function is also there, that is supination. Supination of the forearm, but that supination, because we are catching the hand, probably is not seen properly here. Only the flexion is seen. Sometimes that real movement is not seen. You can just feel the contraction of biceps muscle. That is also positive reflex. Never forget that. Sometimes we feel only the contraction of the muscle. There is no movement of the forearm. That is also considered positive reflex. Now another is supinator jerk. Now supinator jerk, okay, is done, okay, by stroking the knee hammer on brachioradialis tendon. This is brachioradialis tendon, okay, and there is a contraction of the brachioradialis muscle. Triceps jerk. Now see there, the triceps muscle is present on the back of the arm, the upper arm I mean. Okay, this is the triceps tendon. So you just simply stroke, okay, hit on the triceps tendon, and now the opposite type of action would be seen, that is extension of the forearm, extension of the forearm. Or sometimes we can simply see the contraction of the triceps muscle which is present here. So this is called triceps jerk. You have to know the root value of each of the jerk, okay. So this is a special task for you. I'll set some questions, and during that question, okay, I'll definitely ask what is the root value. Now let's go to the lower limb reflexes. This is a knee jerk, and probably this is the most important one which is asked to you from your teachers. See here, ask the patient, okay, to sit on the edge of the bed or on the chair. Both things are fine. Please mute yourself. Somebody is not muting and they are causing a lot of disturbance here, okay. So see there, so ask the patient to relax, okay, and then hit just below the patella, okay, and above the tibial tuberosity. Now there is a pointed bony prominences just below the patella, which is called tibial tuberosity. The patellar tendon, also known as ligamentum patellae, lies between the lower end of the patella and, okay, tibial tuberosity. So you need to palpate that area first, and exactly that area you need to hit. Now what will be the response? The response is extension of the leg, extension of the leg. This is the action. This is the very active type of reflex. So most of the time you will see extension of the leg, but sometime that movement cannot be seen, and during that time you just watch what happens to the muscles of the thigh. These are quadriceps femoris muscle, so there will be contraction of the quadriceps femoris. This is also positive knee jerk. Another one is ankle jerk, okay, ankle jerk. See there, so how we do ankle jerk. So again, ask the patient to lie down comfortably on the bed, okay, on the supine position or on this position, okay, like a prone position also is fine, or even heel knee position would be fine. Now just hit on the, what is the name of this tendon? Which tendon is this?
Achilles tendon.
Very good. This is called Achilles tendon or tendocalcaneus. Achilles tendon or tendocalcaneus. You need to simply hit there and simply catch the sole like this, and the response. What is the response now? What will be the response here? Anybody? Plantar flexion.
plantar flexion.
Very good. Plantar flexion is the action of these muscles. Excellent. Plantar flexion means the sole is going towards the ground. This is the desired movement which we will see. But I already told you, in all the patient I may not see that proper action. So always look at the muscle on the calf area. These are the calf muscles. which are causing this movement. These muscles are gastrocnemius and soleus. Gastrocnemius and soleus. These muscles form tendocalcaneus or Achilles tendon. So this is about ankle jerk. Now, after doing or eliciting all these different deep tendon reflexes, you need to grade them, whether they are normal, whether they are absent, whether they are diminished, whether they are exaggerated. They are also known as brisk, or is there any clonus? Okay. Now see that if reflex is not there, okay, even with reinforcement technique like JENDRASSIK'S maneuver, if reflexes are not elicited, then it is grade 0, means they are absent. Grade 1 means they are present but diminished. Grade 2, they are normal. Grade 3, they are exaggerated or brisk, which is usually seen in upper motor neuron type of lesion. And grade 4 is called clonus. This clonus is a very important feature of upper motor neuron lesion. Now, let me explain to you how this clonus is elicited and what is the clonus. Look at this picture here. Okay. We can either elicit ankle clonus or patellar clonus, but usually, okay, ankle clonus is more commonly done than the patellar clonus. But I'm not saying patellar clonus is not, that important. Okay, it is also importantly done in the clinical practice. Now see here. Okay, catch the sole like this, exactly like as shown in the picture. Okay, and give a quick upward push, or okay, quickly dorsiflex the ankle. Quickly dorsiflex the ankle. Okay, give a good jerk there. Now, if the patient is having upper motor neuron type of lesion, then the knee, okay, sorry, the ankle joint continue to vibrate. The ankle joint continue to vibrate upwards and downwards, like this, exactly like this, whatever is shown in the picture. So this is called ankle clonus. Now, how to do patellar clonus? It's quite easy. Ask the patient to lie down comfortably on the bed with slight knee flexion. You catch the patella with your two finger, thumb and index finger. Okay, catch the patella. Then, just like ankle clonus, okay, or just like the way we do ankle clonus, give a firm push, okay, upwards. Then you can see continuous oscillation of the patella there if clonus is present. Okay, and this is also seen in upper motor neuron lesion. This is how clonus is seen. Now, after doing all these different type of reflexes, let's go to the other parts of neurological examination. Another part is cerebellar function test. Now, see here, what are the different types of cerebellar function test? There are so many types we can go for. You can simply examine for nystagmus. Okay, nystagmus is oscillation of the eyeball. You can go for dysdiadochokinesia. So dysdiadochokinesia. This dysdiadochokinesia is a rapid alternating movement we ask to do in the patient. For example, okay, constantly flip the palm. Okay, flip the palm. The person cannot do that in case of cerebellar lesion or cerebellar disease. Okay, they cannot do that on the affected side. For example, if left cerebellum is affected, probably on that side it cannot be done. So this is called dysdiadochokinesia. I'm sure you have heard this term before. Now this is finger nose test. See this, okay. This is the finger nose test. This is the examiner's finger, okay, and this is the patient's finger. So patient needs to touch the examiner's finger at a time, and alternatively the patient has to touch the tip of the nose. If cerebellum is abnormal, patient cannot do that properly. Patient may not touch the tip of the nose. Patient may touch the cheek, or patient may touch the chin, or maybe forehead, or even the eye sometimes. So this is abnormal type of finger nose test in case of cerebellar lesion. In normal person, they can very comfortably touch tip of the nose and tip of the finger alternatively. Now this is called Hill-Shin test. Now see this, ask the patient to do this type of test. So ask the patient to touch, okay, see here, this is knee, okay, and this is heel. So we ask the patient to roll the heel, okay, on the shin. Actually the shin is anterior part of the tibia, so ask the patient to roll this heel from the lower part of the shin up to the knee. So in a healthy person, they can do it very comfortably, but if a person is having cerebellar disease, they cannot do this. So this is another type of test to know if cerebellar lesion is present there or not. Now another type of test is called GAIT. Simply ask the patient to walk, okay, inside the room or in your clinic and look for the abnormality of the gait. Now in a normal person without any neurological lesion, the person can walk very comfortably, just like we are walking, no problem, okay. But in these abnormal conditions, these gaits are seen. Now festinate gait. Festinate gait is seen in which condition? Any answer?
Parkinson disease.
Very good. This is seen in Parkinson disease. Now Parkinson disease, okay, is a neurodegenerative disorders of our brain, especially the extrapyramidal system. Mainly the substantia nigra of the midbrain is affected there. Now in that condition, the patient have hesitancy. The patient have hesitancy. They cannot, walk smoothly. Okay. So this type of gait is called festinate gait. Waddling gait is usually seen in hip dislocation. Hip dislocation. There is a condition known as congenital hip dislocation. In that condition, they walk like a waddling gait. Waddling gait we can compare with a duck walking. Okay, when the ducks are walking, see, simply like that. That is a comparison. Ataxic gait, okay, is seen in cerebellar lesion. Cerebellar lesion. If cerebellum is having problem, then ataxic gait is seen. A person cannot walk on the straight line. The person sways here and there. And high stepping gait is seen in dorsal column tract lesion. Dorsal column tract lesion or posterior column tract lesion. Okay, this is a walking with a high thud. A sound is heard when the person walks with a high stepping gait. Now let's discuss about another part of the neurological exam, that is sensory function examination. Now one important point you need to understand before we go for the sensory function examination is what is dermatome. Okay, what is dermatome? So let me ask this question: what is dermatome?
Sir, the part of the
Which is supplied by
single spinal root.
Okay, yes, I already got, okay, yes, yes.
supplied by the umbilical, around the umbilicus. So it's a particular nerve supplies to the specific area. It's called dermatome.
Very good. All the students are answering absolutely correctly. So dermatome is a part of the skin which is supplied by single spinal segment. Single spinal segment. Even if you say single spinal nerve, you are also correct, because one spinal segment will give rise to that nerve itself. So it's a part of the skin which is supplied by single spinal segment, that is called dermatome. So remember one thing, sensory examination is done on both sides of the body, and you always have to compare this dermatome. Okay, like let's take the example of T10 dermatome. Now on the right side, if I am examining the T10 dermatome, on the left side also I have to quickly examine that and compare whether it is normal on both sides or not, whether it is abnormal on one side or the both side, like that. Okay, So this is a very important point. Now let's go to the different types of column here. We have posterior column or dorsal column tract, and these are the functions. Okay, this dorsal column tract, they carry different type of sensation. You need to know them first. And these are fine touch, okay, fine touch, okay, then pressure sensation, okay, vibration, okay, vibration. We call something known as stereognosis. When you close the eye and still, if you know what is the shape of that object and what is the, if you identify that object, that is called stereognosis. Position sense, okay, tactile localization, tactile discrimination, all of these are functions of dorsal column tract. So we should exactly check whether dorsal column tract is functioning well or not. Okay, now I have collected few of the picture, and we'll explain with the help of those pictures in the subsequent slide. Spinothalamic tract mainly carries pain, okay, touch, and temperature. Now that touch is a crude type of touch. Okay. Fine touch is carried by dorsal column tract, but crude type of touch is carried by spinothalamic tract. So touch, pain, temperature, this is spinothalamic tract function. Now see it very carefully here. Okay, look at your screen. These are the ways by which we examine tactile localization. Okay. Ask the patient to close the eye. This is very important one. Then touch on some areas of the body where you think the sensation may be lost. For example, in this case, the examiner is touching the face, okay, on one side of the face, and quickly, okay, compare on the other side. This is the elicitation of the touch. Fine touch this is, okay, because the cotton is used. So this is a fine touch examination. Similarly on the sole, okay, and this is a crude touch now. See, I'm using my finger, so this is a crude touch. So the first two pictures are the examination for dorsal column tract, and the third one is the examination of spinothalamic tract because of the examination which I can see here. Now this is 2-point discrimination test. Now see there how the examiner is doing the test. The examiner is taking two pins, okay, two pins are two pointed objects, and keeping them very close to each other, and asks the patient to know how many, okay, how many pins you can feel there. Okay, can you feel these two pins or not? And sometimes patient cannot feel, so we increase the distance between them, okay, and then the patient can feel it. So this is also the function of dorsal column tract. Now let me clarify something more on it. In our body, there are different areas which are either more sensitive or less sensitive. Okay, fingertips are highly sensitive areas. Fingertips. So probably a distance around, okay, distance around 6 to 8 millimeter can be easily, okay, perceived on the tip of the finger. Whereas lips is even more sensitive. Lips. So in lips, maybe we can find around 2 to 4 millimeter distance, but palm and sole, okay, or other parts of the body, for example back is very less sensitive. So in these areas we need a larger gap between the needles. This is the vibration sense. This is the examination which is eliciting the vibration sense. So you stroke, okay, the tuning fork. You stroke the tuning fork. Usually 128 Hz tuning fork is stroked, and then keep exactly like this. The base of the tuning fork is kept, okay, in the joint, okay, or on the bony prominence. In this case, we put on the bony prominence, okay. It can be easily kept on the joint as well. See there, this is the bony prominence. This is a styloid process, and here it is kept on the joint. Ask the patient whether they can feel vibration sensation or not, okay. Now, another very important part of the posterior column tract function is a Romberg test. Now, this lists a bit of explanation, so please listen carefully here. To elicit this Romberg test, okay, I will stand behind the patient or on the side of the patient, okay, you can do both things. Then ask the patient to stand exactly like this. Ask the patient to stand exactly like this, okay. The foot, okay, are touching with each other, okay. Then eyes should be closed, okay, eyes should be closed, and the arms should lie very near to the body, or they should hang comfortably near to the body. This is the position where patient should stand. Now you look for the response, okay, what will happen to the patient. In case of dorsal column tract lesion or the disease of dorsal column tract, if I ask the patient to stand like this patient cannot maintain the balance. Patient sways here and there. Patient sways probably right and left and even may fall. Okay, so to prevent this patient from falling, you should stand very near to the patient. That is the whole idea. So now one question comes here. Why we ask the patient to close the eye? Why we cannot ask the patient to open the eye and stand like that? Now, if the patient fall even after opening the eye, this means cerebellum is having problem. Cerebellar disease. Okay, in cerebellar disease, patient fall even after opening the eye. But this is not called Romberg test. Romberg test is always done after closing the eye. And this is the test of proprioception or dorsal column tract lesion. Now another one is proprioception or position sense. Now see there, ask the patient to close the eye, then quickly move the joint in different directions and ask the patient in which direction your joint is now. Is it upside? Is it downside? Is it laterally? Okay, medially, something like that. This is how a position sense is examined. This is also called examination for proprioception. This is stereognosis. Now see that. Again, ask the patient to close the eye, okay, and put something on the palm, and patient will feel it and then tell you which object is this. So this is called stereognosis. This is also the function of dorsal column tract. Now, temperature and pain are the function of spinothalamic tract. Now, so to check this sensation, we need two different type of test tubes which are filled with hot and cold water. Okay, or if you don't have that, you can also use the tuning fork, which is heated or cooled by the water, and touch in different parts of the body wherever you want to examine, and ask the patient whether they can feel it or not. This is the elicitation of temperature and pain sensation. Now there are three important signs of meningeal irritation. So these are also called tests for meningeal irritation. They are called neck rigidity, Kernig sign, and Brudzinski sign. This is not a new information for you, isn't it? From the last semester itself, we have been talking about that. Now look at this picture. All of you, please focus on your screen. Okay. Neck rigidity is very easy to elicit, which is not shown in the picture. Okay, just ask the patient to relax and simply try to flex the neck. Try to flex the neck. In case of neck rigidity, okay, flexion of the neck will be difficult. It can be done in two different ways: active flexion and passive flexion. Active flexion means patient is doing that flexion by herself or himself, and passive, you are doing, for the patient. Now this is Kernig sign and this is Brudzinski sign. Now Kernig sign, ask the patient to lie comfortably on the bed in a supine position, okay, then flex the hip joint and flex the knee joint also. After that, okay, after that you catch the leg, okay, near the heel area and suddenly extend the knee. Now, this is called extension of the knee. Okay, in the beginning we are flexing the knee, but to elicit this sign we need to extend the knee. Hip is still in the flexion position. So if Kernick sign is positive, patient will complain tightness on the back of the thigh and sometimes even the pain on the lower back. This is called positive Kernick sign, and this is a sign of meningeal irritation. Now, Brudzinski sign is even easier than Kernick. Just simply flex the neck. When the patient lies in the supine position, if there is meningeal irritation, okay, both hip and knee will be flexed. Both hip and knee will be flexed, or they are drawn upward. This is called Brudzinski's neck sign. So these are some of the important points for you. Fine. So after doing all the neurological examination, now the important part is left behind, that is integration of history and physical examination thing which you have gathered. And this is the collection of evidence, isn't it, which you have done. Now what should we do? We integrate all those evidences and try to synthesize a diagnosis. So for that, first of all, we need to ask the question, where is the anatomical localization of the lesion or in neurology system? Where exactly is the lesion? What type of lesion is this? Is this focal lesion? Is this multifocal or diffuse? Focal means in one area, localized to one area only. Okay, multifocal, more than one. Diffuse means most of the part of the central nervous system is affected. Is it located in the nuclear system? Is it in the tract, or is it the whole system? Nucleus means cranial nerve nuclei, or some deeper, okay, some collection of the cell body in deeper areas of the central nervous system are also known as nuclei, like basal nuclei. Is it in the CNS? Is it in the PNS, or both? Now, PNS is peripheral nervous system, and we all know cranial nerve and spinal nerve are the example of peripheral nervous system. So these are the things we should be able to tell after doing taking history and doing physical examination. Now the second, okay, important part for us is we must be able to answer what is the cause of the lesion. Is it congenital or genetic? Is it traumatic cause? Is it tumor? Is it infections or inflammation? Infection or inflammation? Is it vascular one? Okay, is it vascular? Is it toxic, metabolic or nutritional? Is it a degenerative or demyelinative diseases? Is it idiopathic? Even with extensive investigation, we do not find the cause. And is it psychogenic? Okay, this is a psychiatric type of illness. So see there, these are the different cause of the lesion. Okay, so congenital or genetic, some of the disease can be there as a congenital or genetic one. Okay, or some of the genetic disease, congenital disease, for example, some malformation of the brain may not have developed properly. Genetic, Huntington's chorea is one of the example we can take. Trauma, okay, head injury, tumor, these are brain tumors, different types of brain tumors are there. Can take the example quickly. Okay, infection or inflammation, please mute yourself. Infection and inflammation, meningitis, encephalitis, okay, all those things. Vascular, okay, CVA, cerebrovascular accident. Let me mute all of you, people are not listening at all. Toxic, metabolic and nutritional one. Okay, this is the effect of the toxin on the brain. Metabolic disorders means liver diseases, kidney disease, or even hypoglycemia. And nutritional, one of the important vitamin called vitamin B1, if it is deficient, it can also damages the brain. Okay, there may be dementia or memory loss. Degeneration and demyelination, Alzheimer's disease is a classical example of degenerative brain disease. Another is Parkinson's disease also. Demyelination multiple sclerosis is a demyelinating brain disease. Now, idiopathic and psychogenic is very easy to understand. Now, this slide is very important from one aspect. Okay, it will teach you how to localize the disease inside the part of the nervous system, means which part of the nervous system is having problem. Now see there, during your examination, if you find abnormal mental status or abnormal cognition in the patient, then the disease is located in the cerebrum, because cerebrum or cerebral hemisphere, especially the frontal lobe, is associated with mental function or higher mental function. Seizure, if seizures are there, then usually cerebral hemispheres are affected. If there is unilateral weakness and sensory abnormality, including head and limbs, unilateral weakness and sensory abnormalities, including head and limb, along with the seizure and abnormal mental status function, then brain is affected. In affection of the brain, the visual field can also be abnormal, and there may be movement disorder also. So if these things are there, then I can confidently say, yes, the disease must be inside the cerebral hemisphere, either on the right side or the left. Now, in brainstem abnormality or lesion in the brainstem, okay, see here, there are cranial nerve nuclei presented in the brainstem, so they may be abnormal. So there may be isolated cranial nerve abnormality or multiple cranial nerve abnormality. These are important points. The same patient will present with crossed hemiplegia. Crossed hemiplegia. Okay, that means, okay, the face. Okay, if I take the example of seventh cranial nerve or facial nerve, face may be paralyzed on one side and limbs may be paralyzed on the other side. This is called crossed hemiplegia. This is a very important point about brainstem abnormality, okay, or brainstem disease. If there is problem in spinal cord now, the person may complain of back pain, or when we elicit, okay, when we press the spine, there is tenderness. There is weakness and sensory abnormality which spare the head, because there is no reason, isn't it, why the head is affected, because we are talking about spinal cord lesion now. There may be mixed upper and lower motor neuron finding. Okay, this is very, very important point in spinal cord disease. For example, again, if I take an example of T10, okay, T10 level of the spinal cord, if there is a lesion at T10, for example, lower than T10 or below T10, there will be upper motor neuron findings. Okay, at the level of T10, there is lower motor neuron finding, and above T10, everything is normal. So these are the things which happen in spinal cord lesion. There is a sensory level, because till that area, okay, below, if I am coming from below, for example, from the sole, okay, slowly upward till the area where the spinal cord is damaged, there are no sensation, but above than that, every sensation is intact. So this is called a sensory level. And sphincter dysfunction means bowel and bladder dysfunctions are very, very important findings in case of spinal cord disease again. Now, if spinal root is having problem, then there is radiating limb pain, okay, which is known as sciatica. This is one of the example only, okay. Everything is not called sciatica. If that pain is shooting and going downwards towards the lower limb, we call that sciatica. There may be weakness or sensory abnormality following the root distribution, okay. This is called dermatomal distribution, and there may be loss of reflexes as well, because if spinal roots are affected, definitely there will be loss of the reflex. Peripheral nerve, if it is damaged or affected, there may be limb pain, there may be weakness, there is stalking or globe type of sensory loss. This is the most important point here. Okay, this is how the patient comes to you. Stocking or globes type of sensory loss means the distal part of the limb are losing the sensation. The distal part of the limb. In case of upper limb, they are the palms. In case of lower limb, they are the sole. From there, the loss of sensation begins, and they slowly goes upward according to the disease process. And naturally, there will be no reflexes in peripheral nerve lesion. Now, if NMJ or neuromuscular junction is affected, one of the important example of this is myasthenia gravis. Now look at the feature here. There is bilateral weakness which include face and proximal limbs. Okay, proximal part of the limb are more affected than the distal part. And if face is affected, then ptosis, diplopia, and dysphagia are the common features. Now ptosis is drooping up the upper eyelid, diplopia, double vision, and dysphagia, difficulty to swallow. Increasing weakness with exertion is another important point of neuromuscular junction lesion. In the morning, when the patient wakes from the bed or wake up from the bed, the strength in the muscles are all right, but throughout the day, because of increasing exertion, okay, the muscle will become weaker and weaker. This is the hallmark of neuromuscular junction lesion. There is no loss of sensation at all. Sensations are intact. If muscles are affected, then there is proximal or distal muscle weakness. It depends which muscle groups are affected there, and there is no loss of sensation. So this two slides, okay, please revise them many times. They are the summary of whatever we have discussed till now. Now let me unmute you, and then I like to give this task to the students. Okay, please go through this. All of you, please have a look at a screen and try to solve this. Okay, after 1 minute we are going to discuss this. Okay, so please do this. Okay, so let me clarify this. Maybe it may be a bit difficult for you in the beginning. Okay, so let me teach you how to solve this type of cases, because in your exam this type of cases are very commonly asked. Now see here, a 45-year-old male presented to the hospital with complaints of weakness of right lower limb. So let me highlight this so that you know what are the important points. The age is 45 years. Okay, is a male patient presented to the hospital with complaints of weakness of right lower limb. Okay, probably it is paralyzed, and there is no sensation of pain and temperature on left lower limb up to umbilicus level. So only pain and temperature are lost on the left lower limb. Okay, now see here, the weakness is present on the right lower limb. So sensation is lost on one side and weakness is present on the other side. Now on examination, power is 0. There is no power at all on the right lower limb, 0 power. Loss of pain and temperature on left side up to umbilical level, and we all know umbilicus is supplied by T10 dermatome. There is one more physical finding also, loss of vibration on right side up to the same level. Loss of vibration on right side up to the same level. Now where is the site of lesion and what may be the cause? Any student can answer this to me?
Sir,
Yes, sir.
dorsal column.
Cutaneous
The
gracilis.
right
Sir,
side
the
of
problem
the
in spinal
spinal cord.
dorsal column.
Spinal gracilis.
Dorsal
Okay,
column.
Problem in the cutaneous gracilis.
good. So many answers are coming. Okay, very good. So you guys are showing interest here. So please listen carefully. This is a little bit difficult type of task. Okay, now see here. Because the weakness is present on the right lower limb and loss of vibration is also on the right side up to the umbilicus. So the lesion has to be present on the right side of the spinal cord. So it is on the right side of the spinal cord. This is how you judge it. Because corticospinal tract, they do not cross, okay, when they are present in the spinal cord area, and dorsal column tract also, they do not cross in spinal cord. They cross way up when they reach the medulla oblongata. So they do not cross at the spinal cord level. So that is why we know the lesion is on the right side of the spinal cord. Now which level? The level is T10, because they are giving clue to us. It is at T10 spinal segment level. Now another question you need to answer here. Why there is loss of pain and temperature on left side then? Because the fiber which carries pain and temperature and forms spinothalamic tract will immediately cross on that particular level and then go to the opposite side. So whenever spinal cord is damaged, loss of pain and temperature will always happen on the opposite side. But loss of vibration, loss of position, all the functions of the dorsal column tract will be lost on the same side, and paralysis also occur on the same side. So this is the one. And what may be the cause for this? Either trauma or tumor, okay, are the causes. And there is one special medical term for this. This is called hemisection of the spinal cord. Hemisection of spinal cord, are also known as Brown-Sequard syndrome. Brown-Sequard syndrome. We'll talk about that towards the end. Okay, so let me go to the another one. All of you, please try to do this on your own. See this, please. Okay, so let me clarify first and then ask you the question. That will be easy for you. Now here there is weakness of left side of the body, okay, and there is also paralysis of right side of the face. Now see this, face is paralyzed on one side, body is paralyzed on the other side. So clearly this is a case of crossed hemiplegia. On examination, there is lower motor neuron type of facial paralysis, power in the limbs is 0, and reflexes are brisk on the lower and upper limbs on the left side wherever there is paralysis. So this is a very clear-cut case. So where is the site of lesion?
Brainstem.
Brainstem, pons, because there is facial paralysis and facial nerves arise from pons.
Okay, so very good. Many of the students, they have correctly told brainstem is the site of the lesion. Absolutely, but brainstem has different parts: midbrain, pons, and medulla. Now, okay, so the answer is pons. Absolutely, because facial nerve nuclei is located in the pons, and you have a lower motor neuron type of facial paralysis in this case. So this is the way, okay, we conclude or reach to the diagnosis. Now see this, neurology is not very difficult once you know this type of things, So you ask the radiologist, Okay, I'm sending this patient for the CT scan, and please look very carefully in pons. Okay, in pons on right side, if I tell that the lesion will exactly come there, the lesion can be anything. It may be small stroke there, ischemia. It may be hemorrhage there, or it may be pressure because of the tumor. It may be anything. But this is what neurology is all about. So please make sure your neuroanatomy and neurophysiology is up to the mark or standard before you try to learn these things. Okay, all of you, you are having enough time these days, so please go for that. Now we have coming toward the end of this topic. At the end, okay, have a look at this picture, all of you. See here, there is a cross section of the spinal cord. Okay, cross section of the spinal cord. Now what is happening to this patient? These are the clinical features which they have shown here and written also here. On this side, there is loss of pain and temperature. There is loss of pain and temperature on this side. Okay, on this side, on the opposite side, there is dorsal column tract signs, and there is motor loss also. Okay, so this is our first case, isn't it? The first case which I discussed today is exactly like this. On one half, there is dorsal column tract sign and the motor sign. On the other half, there is loss of pain and temperature. So this is seen in spinal cord hemisection, also known as Brown-Sequard syndrome. Brown-Sequard syndrome. So this is a very, very important one. Now, one more for you. Okay, see there. This is the second case. This is the second case which we have discussed. See, face is paralyzed on one side and body is paralyzed on the other side. This is called crossed hemiparesis or crossed hemiplegia. Now, plegia means, you know, complete type of paralysis. Paresis means partial type of paralysis. Okay, almost the same meaning. So this has to have the brainstem lesion, and because face is paralyzed here, pons is the site. So these are very, very important clue for you to make the final diagnosis.